started, when it was started early, in the beginning of the HIV era, there are a lot of ambiguities, whether it is in the treatment, in the diagnosis. There was no treatment at all. Now we have very effective treatment. It is just like any other chronic infection. So at this juncture, I thought it is better to have an idea of the present scenario of HIV/AIDS, as well as a little bit into the future also. So we have today with us very important people. Both of them worked throughout the last decade in the field of HIV/AIDS, and they have good experience in the field. So I think it is not the simple bookish knowledge they have. They have transformed the knowledge to wisdom, and they have great insight into the subject. So we are fortunate to have these two eminent people with us today to enlighten HIV/AIDS. And personally, there's Dr. Vinay Kulkarni. I'm not very much attached to him. That doesn't mean that I didn't know him. So he has worked very much in HIV/AIDS, HIV/AIDS patients. So he will be dealing with basic virology, natural history. And Dr. Ajit, I know him for a very long time, and he is very much into AIDS. In fact, he has changed the scenario in the treatment, diagnosis, management of HIV/AIDS in Kerala. So both are very well versed in AIDS, and we have to get good knowledge from their talk, and we must listen to them carefully. And I wish a good webinar to follow. So I am handing over to Dr. Vinay Kulkarni. Over to you, sir.
Thank you. Thank you, Dr. Edin. And thank you, Dr. Ajit, for inviting me here. I'll start sharing my screen. So with this introduction, actually, Dr. Creighton said that what we are going to discuss is about the present and the future. But I think to understand HIV, we have to look back into the past also, because there are very important lessons learned from that pandemic. And those lessons have come true and to our help even in managing the recent pandemics. Today my topic is about HIV virology, natural history, diagnosis. And that's why I said that we have to look back at the brief history of HIV time. Now, this book by Stephen Hawking is actually said that it is one of the most sold but the least read books, but it gives the brief history of time as far as astronomy is concerned. But here is the origin of HIV and AIDS pandemic. Now, we know that HIV is caused by viruses. There are two lentiviruses, HIV 1 and 2. Both HIVs are the result of multiple subspecies transmissions of SIVs, naturally infecting African primates. Most of these transfers resulted in the spread of humans only to a limited extent in the past. However, one transmission event from SIV chimpanzee in southern Cameroon gave rise to HIV-1 group, and that to group M, which is the principal cause of AIDS pandemic all over the world. Now, we know that there are other group of viruses called simian immunodeficiency viruses, and these are all in the monkey species or ape species, and they are named as SIV. And as you can see on the slide, the note, that is post note, SIV CPZ is SIV from chimpanzee, SIV GOR is from gorillas, SIV MON is from Mona monkey, etc. So these are the SIVs or simian immunodeficiency viruses which have been there in the monkeys. But long back, SIV Sooty Mangabe monkey actually jumped the gun and went to SIV MAC, and then it became a SIV chimpanzee, and from chimpanzee is jumped the species and came to human beings and probably formed the HIV. Now, this is a study. This is you need not go into the details of the figure, but phylogenetic studies. And it is very interesting because human genome does not change very rapidly over time, whereas the viral genomes, or especially the retroviral genomes, change very rapidly. So it was kind of possible to look at the origin of the species, and whatever it is concluded with almost certain amount of certainty is that it was around 1910, maybe between 1908 and 1930s, that this transition occurred, and that too occurred in Kinshasa, which is right now in Congo. So it seems that HIV 1 group M happened around 1910 to 1930. And this indicates that after pandemic of HIV-1 was first emerged, indicates that the pandemic first emerged in West Central Africa, and it spread for almost 50 to 70 years before it was recognized. Now, this is very important to know, because in today's world, we have seen in COVID also that it emerges somewhere in one part of the world and soon it engulfs the whole world, depending upon the virus. But here, because it started in a place which was remote, which was not developed, it was going on for almost 50 to 70 years before it went to the developed world and where the pandemic was recognized. The possible location of the early epidemic seems to be in Kinshasa. Now, these were the first reports of AIDS. It was in 1981, actually. Here you would see that these are not the reports of HIV, because it was not known that time that this was a viral disease. This is very interesting also because at that time it took years, almost 3 to 4 years, for the human beings or the advanced world also to pinpoint the cause. Now the science has advanced so much that nowadays if a new virus emerges, it won't take that long. So in 1981, actually, some reports of pneumocystis pneumonia in Los Angeles, and then some in New York, and then abnormal cancers that started appearing in the people having same-sex relationships, men-to-men sex, etc. And it was a new disease, and it was called as a possible acquired immunodeficiency disease and acquired immunodeficiency syndrome, and that's why the name AIDS came first before the cause was known. It was around 1983-84, two different groups of scientists, actually one under Lou Montaner in Paris and Robert Gallo in the US, actually discovered the virus. There is a nice story behind this, that who discovered first, but ultimately the Nobel Prize went to Lou Montaner for the discovery of this virus. It had different names at that point of time. Lymphadenopatho-associated virus, HTLV3, etc. But ultimately, taxonomy-wise, it was named as HIV human immunodeficiency virus. Now, this is the enemy. This is an extremely small virus. It has got certain structure, and we need to know the structure and the components of the structure. It has got a HIV capsid, which is the bullet-shaped core that contains the HIV RNA. Then there is a HIV envelope, which is the outer surface of HIV. Inside are important enzymes, which we will allude to in a short time. Then there are HIV glycoproteins, which give the virus spikes on the surface, which help it to attach. And HIV RNA is the genomic or genetic material that is contained inside the virus. Now, virology wise, this virus belongs to viruses which are called retroviruses or retroviridae, and the subfamily is lentivirinae. Now, what is retroviridae? Retroviridae are viruses which have the enzyme which is called a reverse transcriptase. And we know that the most important characteristic of this virus is that this is a RNA virus, but in the life cycle, with the help of this reverse transcriptase, it gets converted into proDNA, which enters the human nucleus. So this transition from RNA to DNA is caused by this enzyme reverse transcriptase, and that is the characteristics of this retroviridae. It has got enveloped glycoprotein 160 consisting of two parts, GP120 and GP41, which helps the attachment of this virus to the receptors or the CD4 receptors on the cells. Then there is a nucleocapsid, which has got outer matrix protein, which is P17, major capsid protein P24. This is a major important protein because while diagnosing in difficult cases, we actually look at P24 nucleocapsid protein. Then there is a nuclear protein called P7. Then there is a diploid RNA inside. And there are three enzymes, reverse transcriptase, which we have talked about, integrase and protease, and we will soon see the functions of these proteins. Now, this is a small kind of a virus which has got smaller genes, and for example, there are only 9 genes, and which kind of produce about 15 proteins. Now, to compare this, for example, the E. coli bacterium contains around 4,377 genes, while the human genome encodes around 21,000 genes. Now, that's small. This has got only 9 genes, and the upper one is the genome, and which has got different areas called gag area, pole area, then envelope area, etc. Now, what happens is that the structural proteins, gag makes the matrix, capsid, and other proteins. Pole part creates the proteases, reverse transcriptase, and integrase enzymes. Envelope protein GP120 and GP41. There are certain regulatory proteins called TAT protein, REV protein, and NEF protein. And then there are certain accessory proteins inside the virus. HIV has this classification of 2 types, major types, which is HIV-1 and HIV-2, and then there are certain subtypes. HIV-1 is M, O, and N, whereas HIV-2 has multiple groups A to H. We'll not go into the details, but what we have to remember is that M is the subtype which is actually the maximum spread subtype of HIV-1, and out of that also clade C is mainly present in India. So if someone asks you which virus of HIV-1 is prevalent in India, we have to tell that it is the HIV-1 MC, and that is the most important virus in our country. So distribution of HIV in India, if we look at it, it is HIV-1 is almost 97%, HIV-2 is hardly 2%, and there is a dual infection HIV-1 and 2 seen in almost 1% of the people. What are the differences between HIV-1 and 2? As far as the virulence is concerned, HIV-1 is more virulent than HIV-2. Transmission efficiency wise, sexual transmission of HIV-1 is higher than HIV-2. Mother to child transmission is higher with HIV-1 as compared to HIV-2. And HIV-1 also gets transmitted through HIV-1, but whether it gets transmitted, HIV-2 gets transmitted is not yet known. Progression to AIDS is faster in case of HIV-1, and in case of HIV-2, it is slower. So what has happened is people who have got infected with HIV-2 long back have taken much longer time, and of late they are showing the symptoms, and they have remained undiagnosed for a very long time. As regards response to ART, HIV-1 response is well proven. HIV-2 is also proven, but I would say it is less well proven. We have to remember only in case of HIV-2 that a major class of drugs which we used to use till about 5 years back, that is the non-nucleoside reverse transcriptase inhibitors, nevirapine and efavirenz, they don't work against HIV-2, and so the first line regimen for HIV-2 had to be different. But now that we have shifted our first line treatment to integrase inhibitor based regimen, dolutegravir based regimen, this difference does not anymore count. Now, just for the sake of completing the records, that HIV-2 is very highly prevalent in Western Africa. Apart from that, it is not very prevalent anywhere else. If in India it is HIV-1 subtype C, MC, in US it is HIV-1 subtype B. So this is the electron microscopic picture of the virus, which is budding from the lymphocyte, and this is the structure, and that's how we go to transmission of HIV. Now, how does HIV get transmitted? Since the beginning, within first 3 to 4 years, actually the major modes of transmission of HIV were detected, and they have remained the same. And that's why it is very easy for us to tell common people how to prevent from getting or acquiring HIV transmission, because the modes of transmission have remained the same. Now, here are some slides, and I have used them actually while preparing this, because these were the slides and these were the transparencies prepared by our group long back in 1993-94 for public education, and it has remained same. And so the kind of the morphology of these slides is slightly different. So we know that HIV can be found in many body fluids of the infected person, but only exchange of blood and sexual fluids, that is semen and vaginal fluids, contain them in adequately large number so as to infect others. We have to remember this, because apart from this, there are only two other fluids, that is the breast milk and the CSF, which may contain a high number of viruses, but the major mode of transmission is to blood and sexual fluids and breast milk. HIV can be transmitted only if there is a fluid exchange, that the infected fluid or the contaminated fluid has to enter the other person's body. And so how do we, which are the ways or means in which human blood can or contaminated blood can enter our human body? It's through the transfusion of contaminated blood, or sharing of contaminated needles by intravenous drug users, or using contaminated needles while injecting or doing surgeries, or injuries with sharp instruments which have been contaminated with HIV. HIV can also be transmitted from a pregnant woman to her fetus, and we know that the transmission can occur during all three stages, but the maximum happens during vaginal delivery. There is little antenatal transmission unless there is damage to the placental barrier. Otherwise, the majority of the infection, the total chances of mother transmitting the infection to the baby is about 20 to 25%. However, of this, almost more than 50 to 60% occurs only during the vaginal delivery and through the breast milk, which is another about 20%, and the remaining can happen antenatally. So we have to remember protecting the children from the mother, and this will be covered by Dr. Ajit in the next webinar when he would be talking about prevention. Now, how the sexual transmission can occur? It occurs during the sexual intercourse and exposure to contaminated fluids. When an infected man has sex with another man, whether an infected man has contact with a woman or an infected woman with a man. Now, why I have done this is that the possibility of infection is maximum in man-to-man contacts. Infected man transmitting to women is far more than an infected woman infecting the man. We have to remember that it is only in the penetrative sex there is a risk of HIV transmission. Vaginal, oral, and the anal contacts are probably the most risky. Vaginal come after that, and it has been said that oral sex, the chances of HIV transmission are very, very, very low. However, we have to remember that unprotected oral contact can transmit other sexually transmitted infections. We know also that if on the genitals there are abrasions and ulcerations because of other STIs, the risk of transmission increases manifold. Similarly, in oral sex, if there are oral ulcers or if anal sex, if there are anal ulcers, then the chances of transmission increase manifold. This is just for the sake of the knowledge that HIV does not get transmitted by any other means. So shaking hands, staying together, insect bites, kissing, massaging, hugging, swimming in the same pool, sharing the toilet, sharing the food, none of these ways HIV can get transmitted from one to another. Now, what is the risk of transmission? In blood transfusion, if the blood is contaminated, the risk of transmission is almost more than 95%. One would put it at 100%. Mother to child transmission would be around 25 to 30%, as we already discussed. Sexual transmission, it is around 1%, which means that if there are 100 exposures to person, one of the partners is HIV infected, the chances of transmission is just 1%. Whereas percutaneous, that is the professional exposure or occupational exposure, if we have a needle stick injury, the risk of transmission is only 0.3%. So we have to remember that the risk is very low. And again, Dr. Ajit would be covering the prevention after occupational exposure. Now we have to also remember the life cycle of this virus. And this life cycle is also important because under each heading or each stage, we have developed kind of our interventions or the medicines. So we are going to go into the details, but the different steps are that there is an entry, the virus gets attached to the CD4 receptors. The CD4 receptor, with the help of co-receptor, actually fuses the virus to the cell membrane. CD4 receptors are present only on the T lymphocytes, majorly, apart from some other cells. Then there is a fusion. We have got fusion inhibitors. As regards the attachment, we have entry inhibitors. Then there is the important step, which is called the reverse transcription, in which the RNA gets converted into HIV DNA. This is prevented by our drugs called nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and nucleotide reverse inhibitors. Once this pro-DNA enters into the nucleus, with the help of integrase enzyme, this viral DNA or HIV DNA is integrated into the human DNA. It's kind of splitting into two, putting it in between and attaching the two ends. So now this human DNA, when starts producing proteins or with the help of ribosomes, nucleic acids, it would be producing the viral proteins and nucleic acids also. And this step is prevented by our integrase inhibitors. Then there is a transcription and translation into the viral proteins. These viral proteins assembled together, their long chains are cut by the enzyme called protease into smaller important chains. And once these chains are assembled at the surface, this virus bursts out of the surface, taking the envelope and coat, and this is called budding. And this new virus, which is released, a new virion that is released into the blood, is now free to attach to other new CD4 cells. As the number of this viruses, when this is budding, the CD4 cell dies when the viruses goes out of that, and gradually the number of CD4 cells dying increases. Now, this is again recapitulating that this is the virus which looks like the Chandrayaan lander here, and the white line is the moon surface. It binds to the CD4 receptor. There are co-receptors. This is a drug T20 enfuvirtide, which is a fusion inhibitor. With the help of CCX4, CCR5, the virus fuses and enters. We have a CCR5 antagonist called Maraviroc. Then we have reverse transcription. We have these reverse transcriptase inhibitors. Then we have this nuclear localization and entry inside the nucleus. This is integration. We have integrase inhibitors. Then this viral reassembly happens. There are proteins which come to the surface and assemble together. And this is helped by the protease inhibitor and prevents the maturation. And these protease inhibitors don't allow it to mature. And that's how the virus goes down. And this whole process of the life cycle usually takes about 1.2 days. So millions of copies of this virus are being produced once someone is infected. So this is the infection. The virus enters the cells and produces the virus. And this is the expression, that is a new virus which has budded out of the surface starts circulating in the blood. Now, HIV binds to CD4 receptors through CXCR4 and CXCR5, and if there are no the co-receptors present, then only CD4 receptor is not useful. It is predominantly on the helper T cells and also on the macrophages, and infection of helper T cells by HIV results in their cell death. So what happens during HIV infection? On the left-hand side is the healthy state, where there are a lot of naive cells, there are some memory cells, and a very few effector clone cells. As there is an early HIV infection, the number of naive cells starts going down easily. Then there are memory cells clones that remain. The effector clones start reducing. Whereas in late stage, there are hardly any naive cells left. There are only memory cells left. And these memory cells actually contain the virus. And these memory cells have a very long half-life. And that's why it is very difficult to eradicate HIV from the body. And that's the reason why we require still a lifelong HIV treatment. It does not have a cure as such. So there are certain reservoirs also which we have to remember, and these are the places where the virus can reside with little effect of anti-HIV drugs. They provide low levels of virus in the absence of selective pressure. Selective pressure is the presence of the drugs, whereas in the absence of selective pressure, they provide very low levels of virus. The long lifespan of some reservoir cells allows them to carry HIV for many years. Establishing a cure for HIV infection will thus require a strategy that would require the eliminate HIV from these reservoirs, which is not yet possible. Now, what is the natural history? These are the CD4 cells. Once a person gets infected with HIV, initially, very early days, the CD4 cell counts drop very rapidly. Soon, they establish a low kind of a level, and then they start increasing gradually, but never reach the previous or the baseline levels. This is called the early nadir. And then gradually over a period of many years, actually, the CD4 cells numbers keep on going down. Whereas on the other hand, this is the HIV viral load. Now, early infection, the HIV viral loads could be extremely high when the CD4 counts have reached their early nadir. And after that, body takes control of the virus. The viral loads go down rapidly. Within months, they are established at a very low level. And then gradually, after many years, the viral loads start increasing, which coincides with the reduction in the number of CD4 cells. And this is the time when the viral loads increase. So there are 2 points at which CD4 cell counts would be low. Once early infection, but the CD4 cells low, very low, in late disease comes only once. Whereas in case of the viral loads, HIV viral loads can be very high at 2 stages, early HIV infection and late HIV disease. Now, CD4 cells counts are the T lymphocyte counts, which are the standard test to assess prognosis of the disease. The normal value is between 800 to 1050, the range between 500 to 1400, and CD4 count less than 200 suggests advanced HIV disease, and this was also defined as AIDS. Now, what happens is, before HIV infection, there are these CD4 cells, acute HIV infection, there are a lot of viruses, and therefore the CD4 cells counts go down. In chronic HIV infection, the virus is low, but the CD4s also remain low and they keep on going lower and lower very slowly. At the end of a few years, there would be a lot of HIV in the blood, the viral loads would be high. And in the stage of AIDS, actually, the virus is very high and CD4 counts are less than 200 or even further less. So what happens is, when in acute HIV infection syndrome, almost 30 to 40% of the people may have some symptoms which are generally flu-like, but can have reactivation of herpes zoster, there can be diarrhea, there can be oral candidiasis, but these symptoms usually get treated or get better on its own. Then in the asymptomatic stage, there are no symptoms except maybe lymph node enlargement, but as the CD4 cells counts start going down, the first of the things, the diseases that comes usually in India would be reactivation of herpes zoster or tuberculosis, then oral hairy leukoplakia, and then the skin diseases, and then oral candidiasis, pneumocystis carinii pneumonia, cytomegalovirus, MAC infection, etc., etc. So this stage, when it goes below 200, and person gets opportunistic infections and opportunistic malignancies of HIV, we call it as advanced HIV disease or AIDS. So this is the natural history. There is a primary infection, acute HIV syndrome with wide dissemination of virus, seeding of lymphoid organs. Then there is a clinical latency. Then we start getting constitutional symptoms. Then we get opportunistic diseases, and there is death. Now, what is the natural history of a disease? Natural history of a disease is the progression of a disease if there is no intervention. And we as clinicians and physicians, we should ensure now that no one follows this natural history. The modified natural history or the unnatural history of HIV should be that no one should land in the stage of AIDS. One would remain HIV infected, but the viral load would be zero. Viral load would be undetectable, and the person should be able to live a normal life, and no one should die because of HIV/AIDS. No one should die because of AIDS. Person would stay longer, 60 years, 70 years, and can have death because of other diseases like anyone else, but no one should die because of AIDS. So, what are the stages? Viral transmission takes 2 to 3 weeks. Then there is an acute retroviral syndrome which lasts for 2 to 3 weeks. Seroconversion happens usually at this stage, which is about 6 to 12 weeks if we calculate together. Asymptomatic chronic infection lasts for almost average 8 years. And then symptomatic HIV infection and AIDS, average is 1 to 3 years if there is no treatment. Now, this is a cartoon which I have been showing for many years, for simply to make or explain someone what is CD4 count and what is HIV viral load. Now, this is an infection, HIV infection train, which is traveling on the rails, and there is an impending sight of an accident somewhere ahead. The rail are broken. Now, when the accident would occur would depend on two factors. One is the viral load, speed of the train, and CD4 count is the distance from the site of the doom. So higher the CD4 count, you are further away from the accident. Higher the viral load, you are speeding towards the accident. And so the brakes that need to be applied here are not increasing CD4 count because we have no means to increase CD4 count. The only brakes that we have is controlling the speed of the train, and we apply the brake, that is the antiretroviral treatment, which reduces the viral load to undetectable level, which means the HIV infection train comes to a halt and does not progress. Now, how do we diagnose HIV? Before going to the test, we must remember that the cost of a misdiagnosis of HIV is tremendous, both to the individual as well as to the community. So, ideally, all HIV infected people should be diagnosed before they get any symptoms. Because when they become symptomatic, that too is far too away or far too long time taken for that, and the person may have infected others during that time. And that's why the cost of misdiagnosis would be high. So we should encourage people to get screened as early as possible whenever there is a risk. Otherwise, the most important thing as clinicians is whenever we suspect HIV, we should ask a person to get screened. Try to look at risk-taking behaviors rather than at-risk groups. What does that mean?
Speaker sir, kindly unmute yourself, sir. Speaker sir, kindly unmute yourself.
What does that mean? Try to look at risk-taking behavior rather than at-risk groups, because initially, I remember 25, 30 years back, we were told that screen all sex workers, screen all MSMs, screen all drug injectors, screen all professional blood donors. But for example, a simple example is, if a sex worker is having protected sex with every client, would be far lower risk than a wife, monogamous wife, who is having unprotected contacts with her husband, who is HIV infected, who may be infected because of anything. So it is not dependent on what risk group you belong to, but it depends on what risk you have in your unprotected contacts or when you inject drugs. For example, if someone is using sterile needles for drug injecting, I'm not saying that drug injecting should be allowed, but if someone drug user is injecting drugs with the sterile needles, would be far at a lower risk than a patient who is taking injections in a village or somewhere where the doctor is not sterilizing every needle or not using disposable syringes. So the risk depends on different contexts. So, however, whenever we ask someone for screening, informed consent prior to HIV testing is essential. And we in our country have adopted opt-out consent. Opt-out consent means you inform someone that you want that person to get screened, and that person can opt out of not screening. Whereas the opt-in consent is you have to give informed consent to everyone, and that person has to opt in for testing. And that reduces the screening time, that screening proportion, and that's why we have adopted this opt-out consent in our national programs. Of course, pre and post-test counseling is a must before screening and diagnosis. Now, many people we ask for so many tests without taking any pre-test counseling, etc. Sometimes jokingly, I tell people that imagine you are going for your own HIV screening test and you don't know anything about what the test is about. If you are scared, then you needed some information before going for the test, and you should understand the consequences as well as the actions to be taken after that. So just keeping it short, pre and post-test counseling is a must before screening and diagnosis. Counseling in HIV itself can be a full-fledged talk. Now, what is the diagnostic tests that are available? There are certain serological tests, that is antibody tests, and there are virological tests. ELISA or rapid tests are serological tests which are very commonly employed. Confirmation based on the results of three serological tests is as good as Western blot test, which is a confirmatory test. And if there are any doubtful results with ELISA-based tests. Duo tests which have recently been available, the 4th generation or the next generation rapid test, have both P24 antigen as well as antibodies, and that is supposed to reduce the window period, that is the time taken from the infection to the expression or seroconversion. So during the early phase, P24 antigen is present and it can detect the infection early. However, I tell people that if we have to conclusively rule out HIV infection, it can diagnose early in a few cases, but if you have to rule out HIV infection, then you have to repeat the tests at the end of the window period. The different virologic tests are DNA PCR test and RNA PCR test, but RNA PCR test is mainly used for viral load testing. DNA PCR test is used for diagnosis. It is required in the diagnosis of infants because till around 18 months of age, the baby may carry passively transferred antibodies from the HIV infected mother, and their test could be false positive. Also, virologic tests could be of help during window period. However, one has to remember that even for virologic test, there will be a short, but still there would be a window period. Suppose someone gets exposed and infected today, the test is not going to become positive tomorrow. It still will take some time for the antigen to build, and there would still be some window period. And in case of doubtful cases. So the commonly used tests are enzyme-linked immunosorbent assay, ELISA, and different rapid tests. So there are vertical flow tests like dot blot assays. Then there are agglutination assays which are rarely used. Then immunochromatographic assays which are lateral flow tests. These are again very commonly used. And dipstick or comb assay based on enzyme immune assays. These are also used in many of the laboratories which are handling large number of samples. Ensure that your screening test differentiates between HIV 1 and 2. Now, I said that because of the new regimen containing dolutegravir and 2 NRTIs, the treatment of HIV 1 and HIV 2 may not differ significantly. However, many times what we do is that we don't do a baseline viral load because we know that whatever is the viral load, if we start the treatment with newer effective regimen, At the end of 6 months, the viral load is most likely to be undetectable. However, our standard HIV-1 viral load testing cannot detect HIV-2 viral loads. And HIV-2 viral loads need to be different. And so what happens is, if someone is HIV-2 infected, but it is diagnosed as HIV-1, we may not be monitoring the viral loads properly. And that is the reason why we should, right in the beginning, know whether the person is HIV-1 infected or HIV-2 infected. Now, there is a long list of patients in whom we should suggest screening. So all persons with STIs, patients with identified as being high-risk categories like intravenous drug users, MSM, hemophiliacs, regular sexual partners of people living with HIV, sex workers and their regular and irregular sexual partners, heterosexual persons with multiple sexual partners, unprotected contacts, persons with who all volunteer for any test should be offered test. Never tell someone who wants a HIV test, don't do it. All pregnant women, because that is the only way we can eliminate mother-to-child transmission, which is the most possible strategy for elimination of HIV in one subcategory. Patients with active tuberculosis, I always say all tuberculosis should be screened for HIV. All HIV should be screened for tuberculosis in our country. Recipients and source of occupational exposure, healthcare workers who perform invasive procedures, donors of blood, semen, and other organs. Medical evaluation suggests that there could be HIV infection, and patients with diseases commonly associated with HIV like TB, herpes zoster, molluscum contagiosum, especially perigenital, mucosal candidiasis, lymphomas. Then there are so many, thrombocytopenias and others. The diagnosis is always based on the triad of risk-taking behavior, symptoms, and laboratory tests. However, always confirm positive test result. Never declare the diagnosis unless you are 100% sure, because the consequences for a person, the social, emotional consequences are many. We have already talked about the window period. It is usually between 3 to 12 weeks, and virus can be detected by laboratory tests used to identify virus itself during this time earlier. But the cost-effective strategy would be to wait for the window period and screen again, because this delay of 12 weeks is not going to harm much. Now, which test to employ where? We have to employ tests with higher sensitivity. It is a higher sensitivity means a test that the percentage of those identified having the infection actually have it. So it should have very low chances of false negative. And this is to be employed in places where we are doing massive screening. Or for screening purposes, a test with sensitivity is more important, higher sensitivity, whereas a test which requires higher specificity means the percent of those identified by the test as not having the infection are actually infection free. So there is a very low chance of false positive. And Western blot has high specificity and is so used for confirmation. However, we have to remember that Western blot is also an antibody test. Only thing is that the different antigens are blotted on a paper and the serum is run or the sample is run on that. And depending upon how many antibodies attached to how many antigens, this becomes a more specific test. Screening test, ELISA, is most appropriate for large laboratories where a large number of samples are processed. However, it is not possible in smaller clinics. So what are the advantages of rapid tests? They are more flexible, require minimal equipment and reagents. They are cheaper, does not require highly trained skilled staff. They can be on-site testing done. Very easy to interpret test results because they can be interpreted with naked eye. Samples can be obtained less invasively. Even finger prick whole blood tests are available, and same day results are available actually within less than 30 minutes. False negative ELISAs are seen in window period in conditions where there is immunosuppressive therapy going on or there is a B cell dysfunction, and false positive ELISA is seen in case of liver disease, chronic renal failure, hematological malignancies, multiple myelomas, and other autoimmune disorders. Now, what are the different WHO strategies? For example, transfusion and transplant safety, it is the persons who is receiving the transplant or transfusion is utmost important, not the screening or diagnosis of the donor. And so, irrespective of the prevalence, strategy one is you do one highly sensitive test and you kind of reject the sample. For surveillance purpose, where there is more than 10% prevalence, one can use the same strategy. Where the prevalence is less than 10%, we have to use the second strategy, that is doing two tests, sequential test or confirmation by other tests. In clinical setting for diagnosis, if the prevalence of HIV is more than 30%, even one test would do. But if the prevalence is less, then we go for strategy 2. And in case of asymptomatic people, where we are doing screening to diagnose or to screen to detect HIV infected, when the prevalence is more than 10%, strategy 2 can be employed. Whereas where the prevalence, community prevalence is low, we have to adopt the strategy 3. And what is the strategy 3? For asymptomatic persons, the sample should be reactive with 2 different kits. For asymptomatic persons, the sample should be reactive with 3 different kits. The blood sample collected at one time is tested with the first kit. If it is reactive, it is then retested sequentially with second and third test kits. Remember that the 3 assay should employ different antigen preparation and methodology. In case of indeterminate results, we have to repeat testing or do a more specific test. And in case of negative report, possibility of window period should be considered. In our NACO, National AIDS Control Organization, has recommended strategy 3 for diagnosis of clinically suspected cases of HIV and for voluntary testing. And what is that? You do one test. If it is negative, highly sensitive test, you take it as negative. You have reactive. You have a second assay. There is a reactive or non-reactive. The non-reactive is taken as third assay. It is non-reactive. It is called negative. If it is reactive, it is taken as indeterminate and retested. The third assay is non-reactive, then it is taken as indeterminate. So, third assay is reactive, it is taken as HIV positive. Western blot, we have already talked. Remember that confirmation by 2 or 3 ELISA-based test is cheaper option than Western blot, and the sensitivity specificity is almost the same. And at the end of this, I must tell you that many times I have seen physicians ordering HIV rapid test, Western blot test, CD4 test, and HIV viral load at the same go, which is not correct. We have to first screen, diagnose, do a post-test counseling, and then go for prognostic test. So there is no prognostic testing before confirmation of the diagnosis. I think I have come to the end of my speech. Thank you very much for patient listening. Thank you.
Thank
Dr.
you,
shall I
Vinay Kulkarni. It's very wonderful with exposition of the various levels of HIV. And in fact, I learned a lot. Of course, I was not very active in this field, but with little knowledge, this added to my knowledge of HIV infection. I think almost all the listeners in the webinar have benefited with your talk. And that's why I told in the beginning that Dr. Vinay Kulkarni and Dr. Ajit are into HIV field for many long years, and they have good knowledge and wisdom of HIV. So thank you very much for your talk. Expecting.
Thank you, sir.
Okay. Now, I think the MCQs are not.
Yes.
You have?
Yes, Dr. I have.
Yeah.
Shall
Then you start doing
Yes,
the
doctor.
MCQ.
క్యారెట్ పెట్టేసి నాది అయిపోయింది ఇంకా నేను
Ma'am,
ఇప్పుడేం
I'll
చేయను
keep on muting. Kindly unmute, madam, and keep on muting. Yeah, second question. Yes, your time starts now. Next question. Time up. Yes, time starts now. Yes. Next question. Top question. So time starts now. Yes, doctor. Next question. Last question. Time starts now. Yes, doctor. Time up.
Thank you very much, Dr. Kulkarni. Now we have another important speaker, and I have already introduced him to you, that Dr. Ajithkumar has changed the HIV scenario in Kerala, and he has a dedication in the field of HIV diagnosis, treatment, and whatnot. So Ajithkumar will be talking on the clinical features, opportunistic infection and investigation, diagnosis and investigation of opportunistic infections. And again, as in the case of previous speaker, all will be benefited from his vast experience in the field of HIV infection. Over to you, Ajit.
Thank you, sir, for inviting me. Actually, I grabbed the baton of HIV from you in Kitchen Medical College. And thank you for all the support all along, and also inviting me here for this talk. Vinay, sir, you made my job much easy by setting the stage. I think I can skip a few of the slides which I have prepared, because most of the introductory area is very clear to the audience now. One thing we should remember when you discuss HIV is any disease, most of the diseases manifest and show the manifestations by host-agent interaction and inflammation produced during this inflammation, whether it is fever or there is swelling or all the features of inflammation, which we learned in pathology. But in HIV, it defies the rules. It is the unhindered proliferation of the organism many times makes the disease, not the inflammation, especially in the advanced disease of HIV, because of the immunosuppression. That is, this happens very rarely, only probably in immunosuppressed individuals like transplant patients, otherwise, or advanced malignancy. So this is something very important when you should remember when you address opportunistic infections. This slide is already discussed, so I am not going into the details. This also is discussed. I'll be discussing the opportunistic infections in a syndromic approach, because we all know about the infection, and we are quite well versed with the syndromic approach of diseases. So it can, being a dermatology, we should know how HIV can present in dermatology. So I'll be discussing the skin manifestations, then the conditions where disease presents as fever, then respiratory symptoms, lymphadenopathy, abdominal symptoms, then neurological symptoms, etc. I'll be just going through each disease very quickly because it's a vast topic. As far as skin is concerned, there are some diseases which are very unique to HIV, which presents in dermatology. There are some manifestations which are unique to reduced immune response. There are common diseases which can present in HIV also. Then there are some diseases which are not specific to HIV. Any chronic debilitation can present with these skin manifestations. Then treatment also can cause some skin manifestations and immune reconstitution. Then I'll go to the systems. These are the few diseases which are practically unique to HIV only, like oral hair leukoplakia, Kaposi sarcoma, esophageal candidiasis, can occur in other diseases also. Still, cutaneous cryptococcosis, Penicillium marnefi, bacillary angiomatosis, and CMV infection in the skin and mucosa. So practically we see it in the background of HIV only, even though it can, few of them can be seen in other immunosuppression also. First, oral hairy leukoplakia. It presents as hairy leukoplakia on the sides of the tongue when the CD4 falls less than 350. It's actually Epstein-Barr virus infection, which becomes, all of us are infected with the EB virus in early life, but it becomes symptomatic when your CD4 falls below 350. And with ART, when the CD4 goes up, EB virus disappears, becomes less pathogenic also. So cryptococcal is another disease rarely seen in a patient with disseminated cryptococcal disease when the CD4 is less. And usually patient will be sick, means may have some features of chronic meningitis, and such skin lesions like this, umbilicated papules in a sick patient, you should always suspect cryptococcosis and try to demonstrate this and treat it aggressively. Penciliosis, or new name is talromycosis, is another disease. It's not common in southern part of India or eastern part of western part of India, but it's common in Southeast Asia and Eastern India. It's a multi-system disease, can present with the pulmonary, skin, visceral manifestations, can cause fever, wasting. It's almost like a tuberculosis. It can be a differential diagnosis for tuberculosis, and it presents with skin lesions like this, again, umbilicated papules or ulcerated papules, disseminated lesions with lymphadenopathy, fever, etc. Bacillary angiomatosis, not very common in this part of the world, but still it can present with disseminated multi-system disease with almost any part of the body affected. And these are few examples of this disease. Presents with vascular, the erythematous papules disseminated all over the body with a systemic involvement.
Doctor's speaker line is on disconnected. Shortly is joining. Just be in patience. One minute. Doctor is joining now.
Hello, can you permit me to share? Naveen? Okay.
Just Doctor, now we can share.
Yeah. Sorry for that unexpected. Visible?
Doctor, visible, doctor.
Okay. Sorry for that unexpected disconnection. Okay. Then many diseases which are otherwise common in dermatology can be presented in HIV background with a little different manifestations. For example, candidiasis can have hypertrophic candidiasis, can be extensive or even ulcerative candidiasis. Here's an atrophic candidiasis. There's intertriginous candidiasis, which we see commonly. Melanoprostatitis. There are geographic tongue, hypertrophic candidiasis, etc. So any CD4 we can get, but the manifestation will differ depending on the type of and the level of immunosuppression. And it can be as little as small, less significant as intermittent candidiasis, or can be esophageal extensive candidiasis like severe esophageal candidiasis or even systemic candidiasis. And this is esophageal candidiasis. Another common problem which we used to see in the early days of HIV was severe necrotizing gingivitis due to polymicrobial infection in the tongue. We don't see it very much now. Scabies can present with crusted scabies and scabies incognito in patients with immunosuppression. Here's a patient with crusted scabies. It's another patient with crusted scabies. Here's a patient with herpes, and the same patient had herpes, disseminated herpes. He also had perianal lesions, non-healing ulcer, present as non-healing ulcers. You can see the characteristic polycyclic margins. Can be herpes simplex, primary herpes simplex, or it can be a non-healing ulcer like this, which we may not suspect herpes, but we can see the polycyclic borders. So dermatology is not very difficult to make a diagnosis of herpes here. And the lesions healed just by a cyclovir. Or can be a herpes zoster like this, single dermatome, or a polydermatome, multidermatomal herpes zoster, or it can be a disseminated herpes zoster, even encephalopathy. Histoplasmosis, occasionally we do see, in Kerala we do see histoplasmosis, in eastern part of India also we do see histoplasmosis. Can be, used to be not very uncommon in HIV, since with oral ulcer, hepatosplenomegaly, or sometimes even like tuberculosis, as histoplasmosis by in bone marrow. Other opportunistic infections we commonly see are wart, disseminated wart, can be plain wart like this, or can be common wart. Then psoriasis is commoner in HIV. Raynaud's syndrome is another disease which is linked with same risk factor like STI, sexually transmitted. And it can be common diseases like dermatophytosis, extensive dermatophytosis like this can be commoner in HIV because of the immunosuppression. This is another patient with extensive. We do see this even in immunocompetent individuals nowadays. Tuberculosis can present with generalized lymphadenopathy, scrophaloderma, abscesses, or even disseminated tuberculosis. We used to see miliary tuberculosis very commonly in those days where there was no ART available. Even Davidson, the earlier edition says that a large giant molluscum contagiosum on the face of an adult is an indication to test HIV. It can be disseminated molluscum contagiosum, can be large or giant molluscum contagiosum, especially in the adult. It's a common manifestation of HIV. There's a disseminated molluscum contagiosum, there is a giant molluscum contagiosum. Manifestations of chronic debilitation. These features can be seen in any patient, not only in HIV, like generalized pigmentation, lusterless hair, cirrhosis of the skin, wrinkling of the skin, severe pallor, etc. Sometimes we used to call it the so-called HIV look, with the long eyelashes, emaciated look, etc. And with little bit of extensive seborrheic dermatitis is another manifestation. One of the studies done by Cretins clearly demonstrate that ichthyosis is the commonest skin lesion seen in HIV patients in our part of the country. Manifestation of treatment-related morbidity, a rash in HIV can be due to drug, can be early manifestations, seroconversion, or it can be a concomitant syphilis or many syphilis, or can be a rash due to ATT, anti-TB drugs or Kottayam. So a rash in the background of HIV should be evaluated in detail. Peripheral neuropathy either due to drug, anti-drug, TB drugs, anti-leprosy drug, HIV drugs, or HIV itself can cause various types of peripheral neuropathy. Jaundice can be due to opportunistic infections or due to drug. Lipodystrophy, nowadays we don't see many patients with lipodystrophy, but it was a rule when we were using stavudine. Myopathy, drug-induced, steroid-induced myopathy, HIV-induced myopathy. Pallor can be due to drugs like stavudine or due to chronic illness, maybe due to tuberculosis, etc., etc. This we don't see much nowadays because we don't use nevirapine, just like Sir said in the previous lecture. But it used to be very common a few years back. You can see it was in 2006, or a rash. Maculopapular rash, we already discussed. Manifestations of immune reconstitution. When we start ART, patients can present with the scrophaloderma and underlying lymph node opens up to the skin. Ulcerative herpes was common, and HIV can also present. Sorry, leprosy also can present. Here's a patient presented with type 1 reaction with ulnar palsy and multiple borderline tuberculoid kind of Hansen's disease after starting ART. There's another girl presented with skin lesions which presented after starting ART. It's again borderline tuberculosis Hansen's disease and type 1 reaction. We will be discussing iris probably in the next talk, so we won't go into the details. These are two cases of scrophaloderma. It's presented with the second picture, presented with non-healing ulcer. Actually, she had a psoas abscess. There's another scrophaloderma from cervical nodes. Definitely, when we see HIV, we already discussed when to suspect HIV in the previous talk. And sometimes HIV-related cancers also can manifest in the skin, like Kaposi sarcoma, non-Hodgkin's lymphoma, etc. And cervical cancers are commoner in HIV. Other cancers which may come across are lung cancers, anal cancers, hepatocellular cancer, etc., but not very commonly seen in a dermatology medicine. So let's go to the systemic diseases. When a patient with HIV presents with fever, look for the associated features like cough and dyspnea, go to a respiratory symptom. It can be neurological symptoms, just lymphadenopathy, commonly tuberculosis, or PUO without any other features. Bacterial pneumonia, bacterial pneumonia itself is very common in HIV. All respiratory features need not be tuberculosis or PCP pneumonia. So bacterial pneumonia is very, very common in HIV. Tuberculosis presents with various manifestations. I'll just go across a few of the features of tuberculosis. Can be an early tuberculosis infection which can resemble post-primary tuberculosis, and where sputum smear can be positive. This happens usually in an advanced disease. You may not present with fibrocavitaritis or a late HIV. In late HIV infection, it presents like primary tuberculosis. It may not, sputum AFB will be negative, may show only lymph node involvement or the parenchymal involvement of the various organs, like can affect any organ. Probably I used to say TB can affect in HIV except two organs like nails and hair. Any other part of the body can be affected by tuberculosis in HIV. But in early HIV, it can present with fibrosis like a post-primary tuberculosis. So here's a lymph node aspirate showing AFB in HIV. It can present like typical pulmonary tuberculosis like this, or it can present with lymph node enlargement like this. It can be a progressive mediastinal involvement. can be atypical pulmonary tuberculosis like a consolidation, or even it can be a lower lobe consolidation. In a normal person, we may not suspect tuberculosis in this, but in HIV, you should suspect here also. Or it can be miliary or nodular tuberculosis like this, or disseminated tuberculosis with all over the body. So treatment for that is almost just like any other tuberculosis. But when you suspect a latent tuberculosis, you should treat latent tuberculosis in HIV using there are various regimes which we will discuss. Either it can be a 6 months treatment, 3 months treatment with INH rifampicin, or treatment only with INH. There are various treatment for latent infection. So another common respiratory infection is P-Carni pneumonia, or P0VC is the new name for that. It usually presents with the dry cough, dyspnea, it presents with the subacute disease, mild fever, and which an X-ray shows interstitial infiltrates, ground glass appearance, etc. The typical presentation is patient will have mild fever for a week or so, and on exertion, patient goes into severe hypoxia. This organism can be can be demonstrated by silver stains or Giemsa stain, either by lung aspirate or bronchoalveolar lavage aspirate, or by induced sputum. But most of the time we don't do that by demonstrating hypoxia on exertion in a background of HIV almost, and the absence of other causes for hypoxia. We are almost sure that it is PCP pneumonia, and treatment should be started immediately. It's another demonstration by lung biopsy. And treatment is simple: trimethoprim sulfamethoxazole for 21 days, but the dose is high. Usually we need 2 tablets, double-strength tablet of cotrimoxazole 3 times a day, depending on the weight. It's a trimethoprim 15 milligram per kg per day. Is the treatment of choice. And we should start steroid along with that, especially when there's a hypoxia, because steroids are life-saving in such situation. And any patient who developed PCP pneumonia should get a prophylaxis, secondary prophylaxis. And anybody who has a CD4 less than 350 should get a primary prophylaxis, again with trimethoprim or cotrimoxazole 1 tablet daily till the CD4 increases beyond 350. It's a typical picture of PCP pneumonia. And other system which is commonly affected in HIV is neurological complications like cryptococcal meningitis, which presents with chronic meningitis. So they may not present with all the typical features of meningitis, may have only very mild symptoms like mild neck stiffness or vomiting, or mild features of meningitis. Any patient with immunosuppression, we should suspect, if with any features of meningeal irritation or even recurrent headache or vomiting, we should suspect a chronic meningitis, including tuberculosis and cryptococcal meningitis. So anybody with neurological symptoms, a CT scan if shows a ring-enhancing lesion like this, always suspect toxoplasma and treat it as toxoplasma. Other manifestations which can present are neurological deficit, seizures, etc. And this ring-enhancing lesions around the basal ganglia, multiple ring-enhancing lesions, practically almost always in a background of TB, HIV, is toxoplasma, treated as toxoplasma. You can do a serology to confirm it. And treatment is again pyrimethamine sulfadiazine, which is not easily available. So cotrimoxazole 1 tablet BD for 6 weeks is practically enough for the treatment. And once disease is under control, start ART. Progressive multifocal leukoencephalopathy is rare, but when the CD4 is very low, when patient comes with multiple cranial nerve palsies or neurological deficit, we should suspect that also. And treatment is ART. It is caused by JC virus. When there's so the treatment, I missed this, cryptococcal meningitis treatment is amphotericin with either 5-fluorocytosine or now fluconazole. This cryptococcal is demonstrated usually by India ink stain. And if the pressure is very high, you may have to tap CSF frequently to reduce the pressure. And repeated tapping is of CSF and reduce the pressure is life-saving. GI complications can present with odynophagia, diarrhea, jaundice, etc. And odynophagia usually almost always is due to candidiasis, but remember, rarely CMV, HSV infections also can cause odynophagia, especially ulcers in the esophagus. Very rarely tuberculosis. We used to see sometimes fistulas even into the esophagus, tuberculous fistulas, but very, very rare. And idiopathic HIV ulcers, aphthous ulcers, etc. also can affect, can cause odynophagia rarely. But nowadays we don't see any of this because many of our patients are, or most of our patients are on ART or detected early, but very rarely we do see advanced HIV infection and manifestations of CMA also, or even cryptococcal meningitis also. So when you see oral candidiasis with esophageal with odynophagia, it's almost always esophageal candidiasis, and treatment is prolonged treatment with fluconazole, maybe 2 to 3 weeks fluconazole. And remember to prescribe tablet, not the capsule, because capsule can get stuck in the esophagus. Enteric pathogens, we never see these chronic diarrhea because once you start ART, most of the chronic diarrhea response or any of our patients doesn't reach this. But there was a time we used to see all these infections, patients present with chronic diarrhea with isospora, giardia, cryptosporidium, cyclospora, microspora, and acute diarrheas also. And treatment used to be very challenging. Many times it doesn't work. For isospora, cotrimoxazole works. For cryptosporidium, azithromycin works. But the treatment for this is ART, antiretroviral therapy. These are some pictures of stained pictures of cryptosporidium. We do modified acid fast staining. The fluorescent staining of cryptosporidium, electron microscopy, microspora, cyclospora, and CMV. CMV usually presents with loss of vision or loss of vision, blurring, blind spots, etc. In a patient with advanced disease, always suspect CMV, and treatment is ganciclovir. Now that has become easier because ganciclovir is available as tablets, oral forms. Those days we used to give, it was very difficult to get, and we used to give pyrendrel, and that used to make a lot of problems also, like bone marrow suppression, hepatitis, etc., and renal damage, etc. But now the treatment has become easier. We are experienced in that. But when any patient presents with visual deficit, always suspect CMV and get some help from ophthalmologist. And CMV can present with disseminated disease. Sometimes it can be with chronic diarrhea. It can present with colitis. Can present with adrenal damage. Can present with hepatitis, especially when the CD4 is less than 50. Strong alloids is another thing which we should not miss, because any immunosuppressant user, whether it is HIV or a patient with a chronic steroid treatment for pemphigus or erythroderma or any other disease, and a patient can go into severe gram-negative sepsis when the patient is admitted, when a patient is infected with strong alloids, and it can be lethal. And treatment is very simple now. We have ivermectin and albendazole can be treated easily with can be easily treated with ivermectin. But should remember, when any patient with immunosuppression presenting with the features of septicemia, always suspect strong alloids. All these infections, these infections like tuberculosis, typical or atypical, varicella zoster, herpes simplex, hepatitis B, JC virus, Kaposi sarcoma, all these can present with immune reconstitution when we start them on antiretroviral therapy. We'll be discussing it probably the next session in detail. So, as far as possible, unless the patient is severely immunosuppressed, treat the infection first and start the treatment. The guidelines now says that you can start treatment for both together. But especially in CNS infections, better to get a hold on the infection first, then only start with ART if possible. Otherwise, immune reconstitution can cause problems later. Always remember about prophylaxis, PCP prophylaxis, especially the CD4 is less than 200 or 350. The guideline says 350. And toxoplasma prophylaxis, continue Kottayam prophylaxis. If somebody gets toxoplasma. So 1 tablet of cotrimoxazole can prevent PCP, toxoplasma, and many respiratory infections, diarrheas, etc. So in the early days of HIV, when the TB and ART was not available or affordable, we used to tell our patients that just 1 tablet of cotrimoxazole daily can give you at least 2 or 3 more years of life, because the CD4, the patient develops PCP pneumonia when the CD4 is less than 250 or 200. Next killer disease in HIV is occurs when the CD4 is less than 100. So it takes 2 years for the CD4 to fall by natural history from 200 to 100. So just having cotrimoxazole 1 tablet will reduce the morbidity and mortality. So that's a wonderful drug as far as HIV is concerned. We already discussed HIV. Cancers are more prevalent in HIV probably, and this is probably due to immune dysregulation and other infections like HPV, HHV8, HPV. All these are sexually transmitted, can be transmitted along with HIV, and at least some patients with HIV are smokers, and maybe they have alcoholism. All this can increase the chance of HIV. Let's remember, HIV is treatable now. All opportunistic infections are treatable. Most of them can be treatable even by primary care physicians, and the disease better prognosis than many other killer diseases.
Your time starts now. Second question. Your time starts now. Yeah, next question. Starts now. Yes, last question. Your time starts now. Thank you. The first MCQ results winners are Dr. Nisha from Andhra Medical College, Vizag. And the second question winner is Dr. Yes, doctor. And the
Okay.
second question winner is yes, doctor. Second question winner is Dr. Bhagyashree, HIMS Medical College in Karnataka.
Okay, good, good.
Thanks,
Congratulations.
doctor.
Congratulations.
And the third question winner is Dr. Sri Vaishni from Vinayaka Medical College, Salem.
Oh, good. Congratulations.
Yes, doctor. And the fourth question winner is Dr. Esma from Andhra Medical College, Visakhapatnam.
Good, good.
Doctor. And the last question winner is Dr. Subhashini Konala from GSL Medical College, Rajmandri.
Okay, good. Congratulations.
Yes.
You will
And
receive
give me
the
2 minutes,
prizes.
doctor, on the second question. Yes,
You will
doctor.
receive
2
the
minutes,
prizes shortly. Okay.
Yes, doctor. The
Yeah.
next round win. Yes, doctor. The next the next MCQ winner, sir. The first question winner is Dr. Ajay G. Dr. Ajay G. Dr. Ajay, kindly put your institution name and your contact detail in the chat box, doctor. Dr. Ajay, are you there, doctor? And the second question winner is Dr. Divya D. Dr. Divya D. Doctor, kindly put your institution details and your contact detail in the chat box. Third question winner is Dr. Nitya. Dr. Nitya from third question. And fourth question is again Dr. Ramisha winner from Andhra Medical College. And fifth question winner is Dr. Bhagyashree from HIMS Hasan, Karnataka. Thank you, doctor. Thanks for all the things. And Dr. Nitya, kindly tell the chat box. Right, you can continue, doctor.
Naveen, please post the answers if
Sure,
you
doctor.
have. If you have.
I have, doctor.
Yeah, then
Yes,
post the, I mean, there are a few requests about
sure, doctor.
the answers. So just post it.